This session is really supposed to be focused on care for collagen 6, and I think we can start with just some introductions of ourselves. You met some of us in the last session, and then we're mostly here to answer your questions, and I don't have a good guess about what they are, so we may start with questions. But just to introduce myself in a clinical context, if you heard me the last time, I'm a pediatric neurologist at the University of Utah, where last time I talked a little about our research in genetics of FSHD. That's where my background is in genetics. In the clinic, I take care of patients with all types of neuromuscular disorders, adults and pediatric patients, and I've been doing that since like 2010, so a long time. And we'll pass that.
I'm Brittney Galos. I've been working in the outpatient pediatric field for about 10 years as a physical therapist. I am certified in trough physical therapy, which is scoliosis-specific rehab, and I have a special liking for the rare disease and scoliosis populations.
I'm Reghan Foley. I'm a pediatric neurologist and neuromuscular specialist. I trained in neuromuscular diseases at the Children's Hospital of Philadelphia and also in London, Dubas Neuromuscular Center in the Great Ormond Street Hospital. Mainly focused my research on collagen 6 clinical research since my training time. I'm at the National Institutes of Health, and I am able to see children and adults with collagen 6 related dystrophy.
I'm Payam Mohassel. I'm a neurologist, neuromuscular specialist. I primarily see adults in my clinic. I see patients primarily with muscular dystrophies, including collagen 6 and others, and I have a special interest in seeing individuals with congenital myopathies and congenital muscular dystrophies who come to adulthood, so it's sort of transition of their care in adulthood. I also do research in collagen 6 in my laboratory. I did my training at Johns Hopkins, then went to the NIH in Carsten Bonneman's group for 8 years, worked with Reghan and others there, and then now returned to Johns Hopkins as faculty 3 years ago.
I'm Hemant Sawnani. I actually am at Cincinnati Children's, and I've been there now for almost, in the capacity as a neuromuscular, pulmonary, and sleep specialist for a little over 15 years. This is what I like to do. Questions.
We have a microphone in the back that will come to you. So is there things that are on your mind that you want to talk about? We have some questions to the top, maybe while you're thinking about that. I didn't create these questions, but when I saw the first one, I thought, that's about right. It's complicated. I actually say that a lot in the lab, and they just laugh when I say it, because that's sort of our go-to, like, it's complicated.
Yeah, well, maybe that's a good question, because I see a lot of the Facebook posts within the groups and parents asking questions and stuff, and it always comes up of, well, what's the difference between Ulrich, intermediate, Bethlehem, or A1, A2, A3?
Do you mind if I take you can take the A1, 2, 3? Sure. Okay. So we're going to divide and conquer. So historically speaking, first Ulrich congenital muscular dystrophy was described in 1930. It was clearly a congenital onset muscular dystrophy. And then in 1970s, Bethlehem myopathy was described as a more adult onset limb-girdle muscular dystrophy type clinical picture. But we became aware over time that really it's a continuous spectrum from Ulrich congenital muscular dystrophy with clear symptoms at birth to Bethlehem, what we call now muscular dystrophy, because it really is a muscular dystrophy, and a collagen 6 muscular dystrophy with a later onset, but actually onset during childhood. But we realized we had to define that intermediate group much better. Number one, for parents to know from the child's young age what the future may hold and how to be proactive. And number two, for clinical trials, for stratification, for outcome measures, we need to know where to categorize. And so some children have been called Bethlehem when they really were Ulrich and vice versa. So we need to be have some more clarity. So we embarked on a large study with our colleagues in Barcelona. We looked at a lot of retrospective data and we said, let's look at the maximal motor milestone of a child and how does that predict their future clinical picture? And we have now a pretty good probabilistic model. So if the maximal motor milestone of a child is arising from the floor by pushing off of a chair or furniture or a parent, that's their maximal milestone, that child will most likely have an ultimate clinical picture of Ulrich congenital muscular dystrophy, both in motor function and pulmonary function. If the child placed in the middle of the room is able to rise from the floor using their own legs but not using furniture or anyone else, so independent rising from the floor, the future clinical picture is going to be probably intermediate collagen 6-related dystrophy. If, however, a child can actually arise 4 stairs without holding onto a railing, the probable future clinical categorization would be that of Bethlehem muscular dystrophy. It seems to hold true most of the time. It's not a perfect model, but it gives us a much better idea about who's going to be that intermediate child, the child who can't climb the stairs but can get off the floor on their own, because the intermediate group is not often recognized as needing to be on non-invasive ventilation during the teenage years, which is really important to recognize. We know with the Ulrich patients, they need to be on non-invasive ventilation by about 10 years. And Bethlehem patients older than that. But giving us a better idea from the get-go how to predict the future has been really important.
Yeah, and it's interesting how these things come to rise. Like Dr. Foley mentioned, Dr. Ulrich described Ulrich congenital muscular dystrophy in the 1930s. And you can go back and get the paper, and it's really interesting to look at that, and there's pictures and things. And then this Bethlehem-opathy was defined in the 1970s, but when those things happen in that timeline, they seem like they're distinct when they're really just the same disorder, different spectrum of the same disorder. So, in science we have lumpers and splitters, and so some people want to split, and we've got Bethlehem and Ulrich and intermediate, and those splits actually are really important for research purposes. So, like for me, we want to know that kind of split so that I can look at the genetics and look at what makes somebody Ulrich versus Bethlehem. For Dr. Foley, like she mentioned, we want to predict the trajectory. And so those become important. But at the end, if you sort of think about the biology, they're all the same, right? They're all collagen 6 related disorders. And when you think about the genetics, COL6A1, COL6A2, COL6A3, those are 3 different genes, but they're part of the same protein complex. So I don't know that the disorder is any different, whether you're A1, A2, or A3. They're just collagen 6. So those distinctions are helpful at times and not helpful at other times, depending on the goals. In the research world, they can be really important. This is not just true for what we do, but like in the research world, we define lots of things that we split into groups so that we can do research on them. But those are way less distinct when you get in front of a bunch of patients. And Hemant, do you want to talk about the importance of maybe respiratory care and understanding those disease trajectories?
I'm actually just thinking about what you're saying and trying to recall our Miracin data that we've been trying to publish. But, I think it was maybe it was the Rideau paper that I had. That was the COL6 natural history, right? I think at some point. So, just like Russ was saying, from a clinical perspective, I think, and, I'm a clinician first. The spectrum between intermediates and the Ulrichs, to me, is rather fluid as it relates to pulmonary care, unless it's a very severe one that in infancy requires assisted ventilation. But, as opposed to the Bethlehems, which seem to have a much milder pulmonary course. And a number of these patients will require mechanical ventilation, non-invasive, early on in life. We recently published our Duchenne data, and I was looking at our natural history at our center, and you see this beautiful graph of the decline starting, about 12 years of age, precipitously until about 18, and then it slows down. And this is not the case with the COL6s. Our experience, at least mine, has been that a lot of these young individuals maybe even the intermediates, can still be ambulatory and still have hypoventilation. So our role clinically is to say, what is my threshold and who should I study first in the lab? And my response to that is, I need to get a baseline on the child regardless. So at my first initial evaluation, I always like to know what I'm dealing with, and what you see someone sitting awake, candidly talking to you in front of you, sitting in a chair, may be very different when they go to sleep. I like the idea of being able to see them in the sleep lab because it gives me an idea of what their reserve is, you know. I think the whole pulmonary neuromuscular medicine part has really picked up more attention globally, largely thanks to clinical efforts in, you know, advances in SMA, DMD care, that people now realize, oh, wow, these individuals are actually hitting adulthood, and we need to know what the hell we're doing as adults, care providers. And till today, transitioning these young, smart individuals to adult care is a bit of a challenge. But there is no clear definition on how you define hypoventilation, which is elevated carbon dioxide levels, in the context of neuromuscular disease as it relates to sleep medicine. And so this is right now a global effort that we are a part of to try and delineate, because we then land up fighting with insurance companies. It's nice to be able to reference a paper and say, here, go do your reading, and then sign off on this equipment.
I think we have one benefit we have with Collagen 6 is even though the genes were first discovered in 2001, so anyone over the age, I mean, you know, of like 24, 25, maybe didn't have a genetic diagnosis, and those that are in, you know, in their 20s and teenagers, it may be diagnosed a little bit later, but now the children being born are being diagnosed quite early. It's benefits, we can be very proactive, but we also have the benefit of knowing really solidly the natural history of this condition, and it's been really reinforced. What we see in Europe and the US is seen in Australia, seen in Asia. It's been consistent. So I think that's really helpful to have, and as Hemant mentioned, you know, it is an earlier decline, and it's in the pulmonary function, but we have a treatment. We have non-invasive ventilation in the form of BiPAP, which is what we need to do to help support breathing at nighttime. And we know with the Ulrich patients, they need to be on it by 10 years, plus or minus 4 years. And that's the same data across the globe for the Ulrich patients. Intermediate are by about 19 years, plus or minus about 2 years, and the Bethlehems are usually older. But knowing that's really helpful, so when you go to see your doctor, and the pulmonologists like to be very particular, right? They're very particular, you need to know data.
Only the ones you know.
Yeah, they need to know the data. If you can pull up on your phone, so what we did a few years ago, Dr. Mohassel, myself, and our colleagues at the NIH rewrote the Collagen 6 gene review. So just type in Google, Collagen 6 gene review. It's all in there. And I made the point that everything we said was referenced, and not only the most recent reference, which the editors wanted, every single reference back to 1930 about this condition. So no one can say to you in an ER or ICU, I know nothing about this condition. It's all there. It's all referenced, as well as our names. So people can even just Google our names and find our phone number. So you never should feel that you're, wherever you are in the world, Papua New Guinea or Zimbabwe, you have that data, and you should be able to get the care you need.
Should.
Other thoughts on disease trajectories, or I have one other thought on disease trajectories that maybe doesn't fit these names we've given disorder, but as I see patients, I see contracture predominant kids and weakness predominant kids. And I think that as you sort of split in a different direction now, maybe we think about the care pathway in a different way, where one patient I might be really doing a lot of physical therapy, contracture prevention, scoliosis surgeries, that sort of thing. Another kid, we're more focused on weakness and function related to weakness. So there's different ways you can do that splitting as well. Any thoughts on the PT side of that?
Yeah, I'm sure in all of medicine, but especially in PT, we say you treat what you see, not what's on the paper. So we're always going off of what we actually see in real life in front of us, the people that are right there. So regardless of whether we have a diagnosis or not, a lot of people, they come to us without a diagnosis yet. So we just have to go off of what we're seeing right there. So, you know, it's hard sometimes when you're looking for research and we don't have it yet, or it's a blanket statement across all myopathies, or it's very limited, or it's more about what you can't do than what you can do. But at the end of the day, when we're on the ground with you guys and your families, we're focused on what we can do. What can we do to make you more mobile? What can we do to get you going? And we have to just kind of go back to the basics. You know, when it comes to contracture development, what do we know about contractures? We know that contractures happen when you are immobile and you are not actively weight bearing. So regardless of disease specificities, we do know that to control contractures, we need to get you mobile and we need to get you actively weight bearing. So we can apply principles like that and then optimize them by fine-tuning alignment, getting your equipment, good, get your orthotics in precise alignment. Those types of things to fine-tune as much as we can so that on the ground we're able to maximize your outcomes.
And I would just add to that, one of the biggest things that we've, I think, changed over the years is our approach to exercise that Tina was mentioning in our last session, where we would probably build exercise into a program like that in ways that we wouldn't have in the past. All right, question here. Where's my mic? Oh, Harry's way back there. We caught him sleeping.
I'm slacking. Where's that? Thank you.
A big part of Emmeline's care plan has been stretching, and my wife does the brunt of that, and I think feels guilt when Emmeline doesn't tolerate a lot of stretching and or doesn't want to do her own self-stretching. So, I'm sure we're not stretching enough. We're doing the best we can. That's what I always say. But one thing we found a couple years ago is we just drove through one of these like suburban strip malls, and there's like a stretch lab or stretch zone you might see as well. And we went in and checked it out, and we ended up signing up, and we've been going consistently once a week for a couple years. And it's just easy to go in for 30 minutes and have someone else stretch Emmeline. And I don't think they're like highly trained PT or anything, but it's been good for us, and through a funding mechanism in the state of Tennessee, it's actually paid for through essentially a Medicaid grant. But I'm just curious your reaction to that, if you're like, strip mall stretching, or if it works for us and it's helping Emmeline.
My reaction is that it works for you, and it's not draining your wallet too much.
No, we don't actually pay for it.
Then it's probably okay. And maybe just to broaden the concept of, nobody does enough stretching. I like it. Raise your hand if you feel like you do enough stretching. Like, no hands will go up, probably, right? And probably the same is true of cough assists. I want you to do it twice a day. I'm happy if you do it once a day, and it goes down from there. So there's a point where real life comes up against care guidelines, and you have to negotiate that space. And I think there's ways to do it. So finding a space that works for you is great. And I think you think of other things you can do. I send kids to karate. I send people to yoga. And a lot of those things, they work on balance and coordination and stretching and spaces that maybe seem less like my mom's going to stretch me now because that's my therapy.
Yeah, I just wanted to add to that, not to get on a tangent, but taking care of adults with muscular dystrophies, that's a lot of times part of my role. We cannot do everything for adults. They have lives, they have other important things that they need to attend to that adds to the quality of life. So sometimes it's like a judgment call. So you cut back on this, but maintain that. So the respiratory care is always really important. So you got to do that. But if you want to skip, this and that, it's okay. It's fine. That's life. None of us, exercise enough. None of us, eat as well as we should, because that's part of life. And I think that's also applies to my patients, who have muscular dystrophy, who happen to have muscular dystrophy.
Sometimes delegating to another entity is not a bad thing.
I was going to say the same thing. It's something about the paradox is the parent stretching is the issue.
So think, how old is she now? 12. Think about what you're giving her with that. Not just the stretches. You're giving her the ability to communicate independently to a third party and assert, say, this is what I like to do, this is what I don't want. Tomorrow, when she has an aide, she will have that confidence to be able to direct the aide, hey Jen, I need my white blouse and my tan skirt out today. I have to go so-and-so place. We see this in our DMD boys, that a lot of them just look at mom, and immediately she completes the sentence or the thought. And that's not who we want to make for the future. You want someone also who grows her intellectual facets, her, independence. That's the opportunity that you are getting with this. So don't feel guilty about not doing it. I think it's there are multiple other benefits that are coming through.
On that topic, and knowing Emmeline's very sassy and knows what she wants, just to mention, there's some things that are a little easier for stretching. You can add on this, please, too. Is like I've heard from my young adult patients and older adult patients that just like in a warm pool or a warm bath or a warm washcloth makes it much more comfortable. And then, as Dr. Mohassel said, doing what's feasible. Rachel Alvarez has often talked about her stretching regimen. We know that we can't stop the contractures from progressing, but we may be able to slow them with a nice stretching regimen. What's tolerated?
I have a lot of conversations with my families about how needs are going to change over time, right? There might be periods of time where that relationship with your child and your schedule and your mental health allow for you to be the caregiver that is giving the stretching. And there might be times where that is changing and you have to allot that somewhere else. I have to put my little pitch in and be careful about accreditations, make sure you are trusting in people who aren't certified medical professionals. But if you find a space that you trust and that is working for you, that balance is going to allow you to regain relationship and health in your mental, attitudes and the other worlds that you have. I think a lot of times it's hard enough for us as able-bodied adults and generally healthy adults to get to our doctor's appointments, get to our, the gym, our job, calling back that friend or leaving that text left unread. We're managing that and you're managing your children or yourselves and your health conditions, right? So I try to teach my families to give themselves grace as well. It's okay to mess up. It's okay to forget an appointment. It's okay to not do a home exercise program. It's okay to decide I need to unload this and put it somewhere else, whether it's temporarily or permanently. I think a lot of that is on that pathway of acceptance and discovering what's right for you guys. And that journey isn't linear and it's not the same level of ease or difficulty for every family. So having conversations with us, I think being honest and transparent. My favorite families are the ones that come back to me and say, I didn't do that this week. I can't, or I don't have the equipment you want me to use to do that, right? Because then I can work on something that's actually going to be feasible for their lifestyle or for their home or for their child.
Yeah, I might just make one more just curious observation about physical therapy stuff with kids. In the clinical trials we do, which in the past few years have been Duchenne and SMA trials, we always kick out the parents because the kids do so much better, right? It's just sometimes this just weird interaction there that taking you out of the room really helps. I don't know why, but just the kids. But that just speaks to what I think was saying is it's just their independence coming through and their ability to interact with that other person is a good thing. And so we apologize if we do PT and kick you out.
I'd say take your wife on a 30-minute date. Just do it. You're investing that energy in another spot.
I want to add one other part too, and this is physical therapy or your neurologist or your primary care, is to ensure that your care providers are providing you information, but at the end of the day, it's up to you guys to make the decisions, right? I think early on as a therapist, I thought it was my job to tell my patients what to do. Sure of myself, sure of my research, sure of the literature, of everything that was evidence-based and what was going to get the kid where they needed to be. But at the end of the day, that's not what matters the most. It's our job to give you the information, not to make assumptions about what you're going to do with it. And that works on both ends. I've seen also therapists that don't want to have conversations about bracing or don't want to have conversations about home programs because they assume it's going to be too much for the family. So it's not our role to make any assumptions about what you can or cannot do or are not willing to do. It's our job to provide the information and then work with you to devise a plan that's going to work for you. And also acknowledge that might change in different chapters.
We had a question back.
Yep. Okay, I gotta put up my hand.
I'm going
see.
to jump from stretching to nutrition if I could. I think in our family, stretching has also been a contentious, topic with our son, who also has opinions at this point. But he also has the understanding of what happens when he doesn't, so he can make that educated decision, I suppose. With nutrition, it's another battle that I have let go, and I would like to talk and ask about vitamins and supplements. He is very texture oriented with food. Interestingly enough, like all the bad stuff is very smooth and easy to swallow. Hot dogs, mac and cheese, anyone? And the one with all the dyes as well. Let's just add to that. But feeding in our family, and I'm sure I speak to a lot of the people in this room, became a chore very early on. So we're at the point where we let him eat whatever he wants, no matter how bad it is nutrition-wise, and we try to supplement with good vitamins. I don't know whether that's the right path, but I am looking for suggestions to add nutrients to the hot dog.
I could start, and then you guys, or you want to start?
I'm happy to help. I mean, how old is your son? 12. Yeah, I often talk to the children directly as like, your muscles like protein, right? And so aiming for that intake's key. Balanced diet is the best source of vitamin and minerals. So food's the best source of vitamin and minerals. And so it can be a treat, like, well done, we stretched, let's have a hot dog, not every day. But I think that may help a bit, but knowing that protein's important, but never overdoing the protein either. It's a little bit too much of a stress in the kidneys. So don't go, crazy with like protein shakes, but enough protein, like sources of protein, like poultry and eggs and fish and, in the diet. That's a kind of one inroad, and I think maybe he would understand at age 12 that muscles like protein. It's good for my muscles. Maybe it might help. It's probably difficult.
Yeah.
I think it's the ease of chewing for the most part. He does not want to eat a steak that will take him 30 minutes to chew. I think it has to do with the jaw muscles of some sort, maybe. But no, he understands well. It's just that he chooses.
Yeah.
He chooses that path, and at that age, there's absolutely zero I can do about it, but buy expensive vitamins. Talk about the Nestle Boost. He's not sweets oriented, so it's not that I could reward him with a cookie. He has zero interest in sugar, but carbohydrates are main, thing in his diet, and here and there, any chicken, it's from the chicken nuggets. It's just a very toddler-like. I don't know if anybody else struggles with that sort of thing. Very toddler-like diet, in my opinion.
Yeah, maybe just to dissect a couple points out there. In part, you're just describing the 16-year-old who lives at my house, who doesn't have muscular dystrophy and drinks 2 Pediasures a day and only eats chicken nuggets if they're the ones from McDonald's, because the good ones he won't touch. And that goes stories from there, right? So to some extent, those are not rare or that abnormal, right? That's just part of a thing. In our son, it's a little bit autism related and sensory. In Collagen 6, that you mentioned about chewing and things can be a more physiological part of that, where just you can get contracture in the jaw, you can get fatigue in the chewing muscles, and so some of it could be tied to that. I think there's a lot of complexity around nutrition and relationships between parents and children, right? Because there's like 1 billion years of evolution that says your job is to feed your child, and when you come to clinic, the first thing we do is weigh your child and see how their growth is, right? So like there's all these cultural parts to that are really important, and we have to find ways to navigate. Certainly what won't work is creating a relationship where you're demanding and they're refusing, right? It just becomes a power struggle. In our clinic, we have a good dietitian and good psychology team that can help navigate some of those things. So I think in a setting where that might lead to some bit of malnutrition, you need those resources to help resolve them. And there's a disorder called ARFID that is, I forget even what it stands for, but it's just that sort of picky eating phenotype that can get really narrow, and there's treatments for that. But so you just kind of have to work with your team, I think, to engage and find a space that it's not a battle of wills, and just that can be productive over time, and that may take time. Reghan,
I was going to add, beyond the pickiness, it's also important to be kind of attuned to any decrease in appetite. So around that age, a decrease in appetite for us often can be a symptom of perhaps hypoventilation and retention of carbon dioxide, which affects appetite. So if the child says, "I'm not hungry for breakfast," but used to be a breakfast eater, that can be a subtle sign but important sign. Or, "I'm just not hungry today." Then the weight goes down, and then your team's talking about G-tube. Before you put a G-tube in, check the pulmonary function, get onto BiPAP, because sometimes I think a lot of people can attest to the fact on the way home from putting the BiPAP on, the child says, "Gee, I'm hungry for a hamburger," right? So, right? Yeah, so think about appetite, change in appetite as being an indication of potentially untreated hypoventilation.
I think that's true, because nausea is one of the most common things we would see if there was a GI symptom related to, hypoventilation. It's nausea, particularly if they wake up in the morning with headaches and nausea and they don't want to eat. That usually is what worries us a little bit. But, to what Ross was saying is, I think, a 12-year-old is also trying to find himself in this whole complex world of acknowledging he's different from his peers and is adjusting to some of that. So I think having a good, that idea of having a nutritional team and a psychologist on board is kind of takes you out of the picture of negotiation, but might actually also, attending those visits might give you skill sets to actually de-escalate and to come to compromises. So, life is always about negotiations with our children, right? It's what battle do you want to fight today? And at some point, if it circles around stretches every day or food every day, it gets old. And so instead of rewarding with foods, sometimes what works well is rewarding an activity. And so what our clinical psychologists will sometimes do is, let's say, okay, in a week, if you've done X behavior or participation or whatever behavior change is being sought, if you did X for a certain number of times by the end of the week, that would give you enough to say, all right, we can go and do something fun over the weekend. So it's not like you reward them for each activity, but it's a build-up of over a week or over 10 days, because that allows you to maybe have a good quality activity every couple of weeks or every 10 days. And it's not a tangible or material reward, it's an experiential reward. And this generation is really all about experiences. So that kind of approach might actually warm up that space and maybe even improve communications as it relates to, like, I'm thinking about foods. These are the kind of juices I would like to taste or flavors I like. I've had somebody who actually, where drinking was a problem, but loved vegetables, he would eat veggies. I'm like, why don't you just juice them? So I'll give you an example. Recently, I made the stupid mistake of going to the grocery store when I thought I was going to cook a big meal. And turned out the plans changed, and so now I was left with this huge, large bok choy. I thought I was going to cook Chinese. Is this being recorded? It is. Yeah. All right. I started. So I landed up cooking, but I used the center part of the bok choy, even though it was a nice organic. But all the rest, I juiced with apples, carrots, spinach, and beet. And everybody was like, oh my God, what is this? This is so good. And I finally, after everybody gulped it down, I said, okay, these were all the remaining vegetables that I had left over that I just juiced. And they loved it. And the thing is, it was phenomenal. So yes, a good juicer is helpful when you want to get all these nutrients in. We had families make ice creams, popsicle sticks with some of the juices that they made at home. I think when you do this, you have the ability to really bring quality ingredients, because that seems to be something you worry about. And I think a lot of this is, good quality phytonutrients, plant nutrients, are really incredibly boosting to the body. They rightfully said there's something structured in the web space out there that talks about the fact that nature has provided us everything that we needed to eat on this ground itself. And it can be incredibly, refreshing to have a different take on food and textures when you bring some of these things in that are easy to consume. Like, steaks, the chewing part, that makes me nervous. People get tired. A lot of our patients will get tired. They'll sound junky or gurgly, and that makes me worry as a pulmonologist. So I don't want somebody eating 30 minutes, because even though a lot of the literature says the video swallow studies look okay, I'm like, you doing a video swallow is a snapshot in time, looking at their swallow function, because most people get done with their meals in like 10 or 15 minutes. Nobody sits at the table chewing for 30 minutes. But if it takes them that long, no video swallows goes on that long. We really don't see what's happening once a fatigue sets in. And that's my problem with video swallow studies as a limitation. I feel like the history is where the money is. If you tell me that meals drag on, fatigue kicks in, he loses interest in the food, and that's what happens to a lot of our older, DMD boys. I'm like, the meal should not be stretching that long by the time the food loses taste and temperature.
Can I add a little caveat there?
Go ahead.
Add in a very chatty, conversational patient with collagen 6. It takes a little bit longer.
Oh, and the chatty is different.
Yeah. And that's okay. I want you to panic, because my
That's a good thing.
experience is like there's a lot of conversation going on. It's very interactive, and they're not actually putting the food in the mouth. So that time, take the timer off. Then don't count that as
No,
time.
I actually meant like
okay.
physically
Just checking. Okay. Just checking.
swallowing that.
At my house with 6 siblings, it was less than 15 minutes. Like, you had to go fast and try to get more.
But the boosts and the smoothies are actually really good too, because if the child is a chatter and they're at school and they have a 20-minute lunchtime, they're not going to get the calories in. So put that big shake.
Right, and I think just that's been one space we've seen that can kind of sneak up on families is eating at school, where, if we've been following nutrition for a while and we're losing ground, that's one spot you can look for where the gap is. And the other one is breakfast, if things are just so busy in the morning that they're not getting out, they're not eating in the morning. It's just
I also wanted to quickly comment, since we're talking about nutrition, is the issue of hypoglycemia that can occur, especially in younger children that don't have the reserve of glycogen in the muscle. So, skipping breakfast in young children is not a good idea, and making sure that there is some nutrition on board to avoid those hypoglycemic episodes that do occur in some individuals, especially when they're younger, right? You can speak about the age range a little bit better, right?
Yeah, I mean, we see it more commonly in limb 2 related to muscular dystrophy, but any young child has less glycogen storage capacity, so more prone. So prolonged fasting and missing meals is not a great idea. So sometimes actually these snacks like peanuts or peanut butter, that's going to take a long time to burn through that, are really good to avoid any proclivity or vulnerability to low glucose, low blood sugar.
Okay, I think we got another question over here.
Hi, my question is more about the chewing again. Like, who would evaluate that? Because that is something I worry about with my daughter.
yeah.
Like the taking a long time to chew, the fatigue, the long meals, because that's been a thing for years, but we didn't think about it until recently.
Yeah, I think there's a couple aspects of the chewing, swallowing sort of thing to think about. One is just the jaw itself. So is there a contracture in the jaw? Just like you get contracture in the ankles or the knees, right? You can get contracture in the jaw. So just doesn't open and close efficiently. And the referral pathway would be different on the mechanism, but that would probably go to an ear, nose, and throat kind of person. Is it the swallowing? That might go to a speech therapist initially. And some overlay of those two subspecialists would probably be where you would get those things. To some level, a patient with muscular dystrophy, sometimes it's really, and I know I came in a little bit as you were discussing feeding tubes and stuff this morning. A lot of times that's sort of the end of that discussion, is to getting toward a feeding tube if the contracture is too severe or the time is too long. I usually counsel my patients, if it's taking all day to get your nutrition, you probably need a feeding tube because you got better things to do, right, with your time.
And I think that's an important question. It's more common, or most commonly, an issue in the first 2 or 3 years of life, where there's an inability to gain weight, and therefore a gastrostomy tube is discussed in place. But once you get past age 10 years, again, I'd have a high suspicion of if appetite's low and weight is being lost, you have to worry about the pulmonary function. If meal times are prolonged and there's also inability to gain enough weight, and the non-invasive ventilation is optimized, as a different kind of scenario. But I think talking to our adult affected individuals with collagen 6 would be really enlightening. So I think they have a pretty good system in place, I'm not going to point to anybody, about how to get the calories in and do so during small meals during the day, right?
I was just going to say, if you've ruled out all medical issues, there's no actual physical contractures, there's no issue with your swallow, things like that, you're looking to truly just work on strengthening for chewing, then speech therapists and occupational therapists both run feeding programs, and it runs much like a physical therapy program. You go once a week or once every other week, and they teach you strategies, exercises, stretches, things like that, and then you take it home and work on it.
Rachel's got a comment here in the back.
Thank you, Rachel.
You said adults, so here I am. Kids and adults with collagen 6 don't like to eat great big meals because now we can't breathe, right? So if you keep that in mind, 6 small meals a day, or if they're having weight problems, they're underweight, constantly feed them, let them walk around with a bag of carrots or peanut butter or crackers or whatever. Tiny meals all day is much more sustainable than big full meals because they won't eat it.
I'm curious to hear what it is in the adult land, what you see.
It's variable, right? And a lot of times also we are in some of the patients we're dealing with other common adult diseases like high blood pressure and diabetes and things like that. So you're trying to manage multiple things at the same time. So I have sort of a generic recommendation and then tailor it to each individual. Now, a lot of the patients actually already have the solutions, and they just kind of want me to kind of approve it, right? And so I easily approve, the stuff that makes sense. Sort of say avoid, fat diets, intermittent fasting I don't recommend, things like that. But as long as it's a general good thing that works for that individual, can fit in their schedule, with work, with other activities, with college, and it works and it seems reasonable. Generally, it's approved. But I don't have any specific recommendations necessarily to do this or do that. Kind of listen what they're doing and make sure it's within the ballpark.
But if I may, I think there are, in childhood, the adolescent phase is tough for a variety of reasons, but they also are experiencing a potential impending growth spurt, so their caloric needs are going to go up. And so if you're seeing limitations in their ability to clear enough food on a daily basis, it might come across as either worsening strength profiles or they just start losing weight. And I think both of those need more aggressive discussion with the primary medical teams.
Right, And maybe just to reiterate the point on, I think if we think about where the spaces we can intervene and really help someone with collagen 6 or other muscular disease, nutrition and pulmonary are like my top two things. And all these other things that we talk about that we stratify by priority of contracture prevention and other things. Like if I can get pulmonary in a good place and nutrition in a good place, then we can figure out the rest of it. So just as a general rule.
On the topic of, since you brought up supplements, don't forget iron, because we tend to skip that, gloss that over. And I say this like general pediatricians do this very more often, probably it's kind of what I see, I guess, particularly in my sleep clinics. Don't forget about the iron, okay?
Thank you. We have one more comment over here.
That's all right. I'm Lizzie. I'm the mother of Charlotte. She's 9 years old, and she's the pickiest. I'm also a registered dietitian, and if anyone wants to pick my brain, I could give you a list of brands and ideas of how we've found, to get Charlotte to eat. But one of the things that I would want to offer every parent in here who has been like me and you want to pull your hair out, but you're really doing it from a place of love, is just to remember that it doesn't have to be perfect. And just layering is so important. So like a little bit of food dye and a little bit of something else. Like a little bit of like whatever chicken nuggets and a little bit of something else. And little by slowly, the exposure to what you want, little by slowly, that gets into their brain and their consciousness. And all of a sudden, we have Charlotte who's eating beans and tofu and whatnot. She does not like to chew either. But prioritizing the protein, so important. And we found smoothies and shakes, like bottled shakes, I could give you brands if it's helpful. But anyway, if anyone, wants to pick my brain at any point, I'm happy to give you my email or just help you, so.
Thank you.
Thank you. Excellent.
Hi, Susan. I just wanted to add, in this conversation, and maybe this is many years ago, but there's such an emphasis on weight, which, yes, it's important, but at some point there seemed to be sort of a push, I don't know, like for fats and corn syrup and a lot of things so that you will gain weight. And then what I noticed was my son's body had this trigger, right? He said, I'm full, like I can't eat anymore. And so it's this delicate balance again. You're going to get a lot more in when you're not quite as full because you're not eating as much. Some of the things that were, butters and a lot of the fats. So it kind of just reading his system and making sure that we weren't, also it had a Nissen fundoplication and things like that. So, not getting full so quickly. And then the slow motility as well, right? Also that was involved. And so, I just wanted to add that.
That's right. Higher fat foods take longer to clear out of the stomach. That's why. But a little fat is good for satiety.
Another one up here.
Hi. My question is about scoliosis management. My daughter, Chloe, is 6 years old. She is in a brace because her spine is at 65, I think, the last we checked. The brace has really taken away her mobility. So she's in a chair basically full-time when she's in school. At home, we have the walker at home, so we'll have her try to bear weight in terms of that. But then the bracing, she's supposed to be in it for 21 hours also. So we're trying to figure out what's the balance. So is there anything that we can do in terms of PT? She's already doing aqua once a week as well as hippo once a week. But is there anything that we can do for her to manage the scoliosis?
It's a very loaded question. Yeah, you're always balancing the needs of the brace that's going to help hopefully slow down the actual curve. As mentioned earlier in the orthopedic section, a lot of times these scolioses aren't preventable 100%, right? We're just trying to slow them or stop them or get them to surgery at lower angles so that we have, shorter procedures and safer, more effective outcomes. But sometimes in more milder curves, we can have influence and we can help slow or stop these curves. But then you're always balancing the pulmonary aspect. Anytime you put a brace on a child that is already having issues with breathing, it's a double-edged sword. Anything you're going to do to help that is going to worsen the breathing. But then if the curve gets worse, that also affects the breathing. So you feel really, tied. I think you have to have a really close assessment with a therapist who understands the condition. As I mentioned before, I'm Schroth certified. It's a scoliosis-specific approach, and what I've learned more than anything in going into that area is that even your average physical therapist does not know very much about physical therapy unless you have that additional training. Once you get into that realm, you really start understanding a lot more about positioning, posturing, things even like weight bearing. So both loading and unloading, passive postures. Depending on which way your curves are going, there might be side-lying positions that we can prop you in where gravity is actually going to help you bring that curve down even just ever so much. So if you are able to seek out a Schroth physical therapist in your area, that's going to be of great benefit. Now, Schroth is meant for idiopathic scoliosis, right? It's not designed for neuromuscular populations, but we modify and we use that and we adapt it to our neuromuscular populations, and we've had some success with that.
Just add with the, it's like to brace or not to brace, that is the question. It's a very big question. So no bracing at nighttime while sleeping. And I think you already know that, but if everyone to know that. And why is that? Because the diaphragm in collagen 6 is predominantly the muscle that's most affected of all the respiratory muscles. So we've done in vivo MRI imaging of children with collagen 6-way dystrophy breathing. Diaphragm barely moves, but the chest wall is hyperdynamic. So you don't want to prevent that chest wall from moving. So when she's upright at school, it's okay. 21 hours is very, wow. It's a lot of time. It's, it's very ambitious. And so I would say it's probably a hard brace too. Yeah. So I think what's tolerable during school, sitting upright is okay, but we've done pulmonary function just to kind of prove it to ourselves, pulmonary function in and out of the brace. It's very different. But it's most different when they're lying down or supine. So as long as she's not in it while she's sleeping, during the day, some bracing. We haven't found an ability that we can prevent it. We can maybe slow it, you're saying slowing, but we can't prevent it in collagen 6-way dystrophy.
Is she using the cough assist? How often?
Twice a day when she's well, like 4 times a day. And
You
when
get a
she's
gold star.
And then usually we've decided as parents not to brace at night. So kind of story, she was bracing at night, came down with double pneumonia a few months after, and then we were in the hospital. Kind of back to the old story about the oxygen. I can share more privately. But anyway, on the BiPAP, and then Dr. Floyd, to your point, I think she's gained about 8 pounds since she's been on the BiPAP in less than a year. Like, appetite is pretty good, so like that's one thing. But part of the question was, so we don't really tell her ortho that we kind of tell them we're not doing it in sleep, but she really only gets about 6 hours in the brace. And I think even the 6 hours, I know from their studies they say it doesn't work, but her curve was going about 9 degrees each 6 months checkup, and then when she braced last time, it only was about 5 degrees, and that was only within 6 hours, so we were happy with that. But part of the question was with the BiPAP, usually around age 10, like she's only 6, and I know you said plus or minus 4. Does that mean it's more severe case, or is it just doesn't really?
I think we're being more proactive. I mean, our site, we actually looked at our data. We pulled all of our collagen 6 data compared to the data I published in an international cohort, and we're starting BiPAP earlier, just because what I learned from the international cohort, which was a lesson, was never wait until it's an emergency. So we're being super proactive.
Okay.
Right. And like one of the outcomes of Reghan's data is that we probably look harder at younger ages so that they start earlier.
Okay.
So you bring up some really important elements of how we, at least at our center, and how we teach our trainees, how we need to really be looking at sleep studies. Point number 1 that you mentioned is you started the brace and she landed up with double pneumonias, right? So very often it's not really a pneumonia, it's really collapse. I mean, pneumonia typically requires fever, cough, congestion, yeah, and she probably didn't have any of that. She just got sick, congested. And that's because we splintered the chest and didn't let it move. So the second thing is that she gained weight after starting on BiPAP. That tells you how much energy these children are burning through just to maintain weight at night. And I think the third thing is the fact that she gained weight so quickly after that is probably what's also caused her spine to turn more quickly. And we see that in, like, even in patients with cerebral palsy, the moment they get a feeding tube, they gain weight, and in 6 months, their spine has gone to like hell in a handbasket. So you gotta really be careful. To me, in my mind, given where she is now at her age, we can talk a little bit further offline about exactly the nuances of the cough assist setting and what we're trying to achieve over there. But one of the things that we do think about is there something we can do to prevent the spine from turning? And totally, I fully submit that scoliosis is a part of neuromuscular disease. But children who are born with one lung and normal muscle strength will develop scoliosis to the side there's no movement. So once scoliosis tends to start and you throw on rapid growth, it can accelerate. And what happens is the chest, instead of behaving as one thorax, becomes two hemithoraces. They seem to have somewhat asymmetric physiologies. That one side has a narrower angle and the ribs are really crowded on a chest x-ray, and the other side, they're really splayed open. So what happens is one side of the chest, when you look at them, it looks like one side moves a lot more than the other. Consequently, their breathing in time is short. So air takes the path of least resistance, fills up one side more than the other, and it becomes a self-fulfilling, miserable spiral of accelerated scoliosis. So that's what we're trying to break when we use our cough assist, and to try and stretch both sides. So I advocate for a lower pressure but a longer inspiratory time so that we give both sides time to fill, and try and buy time as much as possible so she gets one spine stabilization in future.
Okay, awesome. Thank you.
I saw a question over here. So.
My name's Cody. My daughter is Charlotte as well. Just continuing on the scoliosis question, we actually have a visit with our doctor, I think in 2 weeks, and we've been using the night brace for, I don't know, 3-4 years, and that was a lot of back and forth on the discussion of that. Our daughter was not comfortable using it at school. We were worried about her not participating in activities as often, and so she fought pretty hard to have the night brace, which to me blew my mind because I just can't imagine sleeping in that. She's by far the best sleeper in our family, and that's with the night brace on. Can you clarify, just because I don't know what you were saying about the concern of using the night brace?
Yeah, of course. So the diaphragm is a very thin dome-like muscle, and it's affected in collagen 6-phase dystrophy actually more than the intercostal muscles. So we look at kids that don't have muscular dystrophy next to kids that have collagen 6 muscular dystrophy. The kids with collagen 6 move their chest wall more than the kids without muscular dystrophy because they're making up for the diaphragm, which isn't moving. So they're basically compensating. So it's compensatory movement. That's why also the cough assist is good because it's stretching that chest wall. So having that chest wall being hyperdynamic is making up for the diaphragm. When you're upright, you have gravity. It helps that diaphragm move. When you're lying down recumbent and you're in deep sleep and your muscles really don't have the benefit of the gravity on the diaphragm, you're going to be more vulnerable for hypoventilation. And then also if you have a hard brace, you're restricting the movement of the chest wall. So thankfully she's done well, but long term it's not great because if you look at the pulmonary function, you can't move the chest wall, you can't exhale as effectively. And why do you need to exhale? You need to breathe off the carbon dioxide because that hypercarbia, or that high carbon dioxide, is what happens naturally as part of the natural history of collagen 6-phase dystrophies. it's all part of it, but we know how to treat it with non-invasive ventilation. So we've learned so much through the years about how to treat it, how to be ahead of the curve and keep our patients out of the hospital ideally and doing well and thriving, living their lives. That's one nuance we looked at carefully. And we've actually checked that with kids in and out of a brace doing pulmonary function testing. It's a little bit different based on that just restriction of movement of the chest wall.
Is having it on causing a further progression? And we don't have a cough assist.
You do? Or you do, you said? You don't?
We do not.
Okay.
She hasn't shown needing it yet.
Okay, okay. And they're checking the pulmonary function testing?
Yes.
Yeah, okay. Yeah, we use, I should to be summarize it, we use the forced vital capacity, that FVC, usually the top number, that percent predicted to kind of be a surrogate measure of the overall respiratory muscles in your pulmonary function. So when that forced vital capacity is declining below 60%, we prepare for the initiation of non-invasive ventilation in the form of BiPAP, because once you hit 50%, we've known by doing sleep studies in a child with 50% forced vital capacity that all those kids are hyperventilating. So we know at that point they should be on BiPAP at 50%. We start being actively working towards getting on BiPAP at 60%, because it takes that much time to get the sleep study and everything teed up and the titration and the BiPAP. Years ago, kids were not getting onto BiPAP until they were at a forced vital capacity of 30%. But those kids suffered long and complex hospitalizations. And so we're trying to get ahead of that curve by getting the BiPAP on before the forced vital capacity is 50%.
Often even higher, because when you're upright, all the belly contents fall off the diaphragm, so diaphragm movement is a lot easier. When you lay down, dynamics changes. So the abdominal contents push the diaphragm up to a little higher resting position. And as a consequence, you have lower lung volumes. Lower lung volumes has a higher tendency to collapse, which is what happened over here. So if someone were to, if you had an adult, so in adults, we define diaphragmatic weakness as clinically significant if the lung function drops by 25% from an upright to a recumbent position. We have a lower threshold for children. So if she's at 80%, when she lays down, goes to sleep, she's probably at about 60% lung capacity. That difference may be enough to cause her carbon dioxide levels to creep up in sleep. And so she's going to breathe faster and shallower, but she may not still have an abnormal carbon dioxide level. And that's that window where I feel like we need to intervene and start them on support rather than waiting for them to have an abnormal carbon dioxide level and then you're playing catch up. So our entire effort, like this whole panel in all the rooms, is intervening at that right point before you really feel like the shoe's about to drop.
Yeah, I might just make another comment on the pulmonary function testing. It's just, and that's a peculiarity of collagen 6, not unique, but just one of the things of collagen 6, that the diaphragm is weak like that. So even in a neuromuscular clinic, it might not be standard to do pulmonary function testing sitting and laying down. But for certain disorders, it should be, even if you're not doing it. For a Duchenne patient, it's not as critical. You could probably argue with me, we should do it all the time, but we don't, just for time and things. But for a collagen 6, that should probably be more of a priority, I would say.
I'm just going to assume it when you do it. I'm not going to waste time getting a second lung function because I get into too many fights in my own division.
We had another question over here.
Thank you. Good afternoon. I had a question about the contractor management. Is because we had an appointment with the doctor and we are trying to decide if we do the surgery in her right hands just to prevent that contractor. But to be, it's gonna be, he explained us that it could be with the nerve block, now under completely anesthesia. But I am really concerned because the thing is that she wants, and she is all the time determined, I have to and I do it. But I don't know if it could be a good idea or not.
we probably share this answer with my adult expert here, but yes, you have a very intelligent young lady there, and a very good question, very good questions, and you're right-handed, right? Yeah. So it's natural, right? You're right-handed? Yeah. Yeah. Natural on the dominant side when you're active. Go ahead, tell me.
My left side is fine, like I can use it.
Yeah.
But my right, I can only drive with it.
Yeah.
And write.
Yeah.
But not use it more.
Yeah. So, but it's your dominant side for driving, right?
Yeah.
Yeah. Yeah. And we have patients who actually drive cars as well with your condition, and that would be your driving hand. So that's why it's such an important question, right? And why is it something that we often don't recommend? It's because the cartilage, the scalpel of the surgeon touches the cartilage or the tendons, more specifically the tendons, the cartilage. If you're actually doing surgery on the tendons and the cartilage, there's collagen 6 expressed there. So just how we see sometimes keloid or these kind of rough or raised scars that happen in collagen 6 trait dystrophy, when there's healing, whether it be of a cut or of a joint that had surgery on it, sometimes the body will lay down collagen 6, which has a different conformation. So it's like a scarring then at the surgical site, where you may then have what's called a fixed contracture, whereas then no movement, neither direction. So kind of frozen, and that's what we want to avoid. And so we say in general, besides the Achilles tendon, that kind of percutaneous release surgery, we don't recommend surgery performed on any of the joints, and that's from experience. So we've had a child who had a quote-unquote meniscal repair because a well-intentioned surgeon said, I'm going to fix your meniscus. She was ambulant preoperatively with collagen 6. Postoperatively couldn't extend or bend her knee and stopped walking. We had a girl who had an elbow contracture released. Preoperatively, she could reach her mouth. Postoperatively, she was frozen, couldn't reach her mouth or a doorknob. So for that reason, we're really cautious. Now, if it would be a soft tissue type of only surgical approach that was discussed with the neuromuscular team, maybe, but I suspect they're thinking of working on the actual joints.
Yeah, they said to release the joint.
Yeah. Do you want to add?
Yeah, I think that specifically for collagen 6, the outcomes are not what's intended, and it sometimes ends up you end up doing worse after surgery. Then, now you can't say that 100%, but that has been the trend, except for when they released the Achilles tendon. That's the one that's pretty straightforward, and it does help at least temporarily. So I generally do not recommend any other joints essentially to my patients.
We had one other question over here.
I was just going to say, for surgeries and things like that, a lot of times where I see patients, have trouble afterwards, is that for a surgery to be successful, you have to be able to follow up with the proper bracing. You have to be able to follow up with the proper rehab. And so often we see patients lost in the system after things like that, especially when you have a rare disease that perhaps your local team doesn't fully understand. A lot of times we try to kind of guide our patients first to try serial casting and use that. It's a much less invasive. It's not technically invasive at all, it's just time consuming. And use that for a slow stretch effect. So you're really using kind of like the creep phenomenon and using the tissues to stretch over time. The focus is just making sure you have proper alignment, and we would probably expect, I don't know if there's really literature on this yet, but a longer duration of serial casting than, say, a kiddo with like CP or a more common neuromuscular disorder.
I want to go back to pulmonary for a second, because something you said earlier just made alarm bells ring. I wasn't aware that the diaphragm does not move at all with collagen 6, and our boys are 3.5. They have annual sleep studies, and they do not have a cough assist. I just worry that we're not being proactive.
3.5, yeah. So you can breathe deeply because there's a little bit of diaphragm movement, just it's very weak. But by 3.5, so based on our natural history, if you're doing the sleep studies, we haven't seen a need for non-invasive ventilation at that young age. So again, maybe 5, 6 being more the younger end there, but 3.5, based on in this robust natural history, we're talking internationally over 250 patients who've been followed with serial pulmonary function testing. So that age it should be fine, but still doing the pulmonary.
And in terms of like cough assist as well, because we haven't really had a conversation with the pulmonologist about that, but she's a general pulmonologist, not a neuromuscular one.
Yeah, that's more of a newcomer on the scene, but not newcomer being like, I don't know, 2012 or so, but
I feel like you got nothing to lose when you start, you know, because even getting acquainted with the machine, getting acquainted with the technique, the child getting comfortable, you know, when you're not learning something new in a crisis, it's so much nicer than suddenly coming up to a point and you're having to play catch up. And that part I struggle with because I know what I want to achieve. I just sometimes feel hamstrung because, you know, either people are too far or it's insurance issues, things like that. But so much, I think, depends on just chest wall mobility for me. And if I feel like the mobility is not what I would want, you're getting hyperinflation therapy until...
What is that? What is the, sorry, not to be a stickler, but what's the range between not needing it and a crisis? Like where...
So that's where I think when people realize, oh, he's had a pneumonia, or he or she has a cold and it lingers.
Okay.
And, you know, I feel like by then you've missed multiple opportunities to start something going. Because the very fact that a chest cold lingers means what? One, there's a function of weakness, but the other part is that you can't even deform the chest enough to inflate it fully. And so, you know, when we talk about cough, there's two aspects of this. One is getting air behind the secretion, so you need that deep inflation. For that, the chest needs to move. The second is that deforming force that takes place when you actually expectorate secretions or cough it out. So that also is a deforming force. So the chest has to move on both sides of the zero, you know? If you think of I don't know why I'm saying this tangent galvanometer, but if you think of a 0 point on an x-axis, the chest has to move on both directions. You can't only move it one way, you know? So that deforming force is really important. As we see the contraction of what we call the vital capacity, that's the amount of air you can take in between a peak inspiration and a peak expiration, that whole difference. So if you all were to just breathe out until you couldn't breathe out anymore, and then took the deepest breath in until you couldn't take anymore, that is your vital capacity. We don't function at baseline there. I want you to think of like a 3-story building where you are on the 2nd floor. The 1st floor and the 3rd floor are your reserves, which you tap into when you run up a flight of stairs, things like that. So if those two start converging, because the floor of one is coming up and the ceiling of the top one is coming down, you're not even aware of that until you on the 2nd floor are finding you have no headroom. So it's about reserve, and it's about giving these children some more resilience to deal with a cold, to deal with a flu, to deal with congestion, you know, to be able to physically be more active, to blow out candles. That's the reserve I'm talking about. And so waiting for that level of tightness to me it makes me uncomfortable because I feel like they missed opportunities.
But don't worry at 3.5, just to say, because for many, many years we didn't have a cough assist. Then it came onto the scene. So I call this the miracle worker. It's available, which is great. Why is it a game changer? When it comes time for a cold, it won't go down to become a bronchitis or a pneumonia. So you haven't missed the boat. You're just getting the cough assist in the works, and that's great.
That being said, I have not seen the children. So my perspective may be skewed by what I'm trying to prevent. But there have been cases that I look at these kids and their chest rises are phenomenal. I'm like, I don't want to add to your burden of therapy for the day. So we do make those decisions on a case-by-case basis.
Right. And maybe I just add one more thought, just by way of a framework, how to think of these things, because I think the cough assist is unfortunately named device that makes us think it's all about your cough. Right, but it's about your chest wall mechanics too. So you think of that like you would think of a stretching program for your hamstrings or your ankles, especially in the disorder like collagen 6, where those contractures can happen in the joints of the chest wall. So it's not all about the cough, and I think that we have to kind of keep in mind as a framework.
Yeah, that's very helpful. Thank you.
Are we doing okay, Rachel? Okay.
Were there any other questions? Oh, I thought you were raising your hand.
Good, we exhausted you.
We got some things up here.
Okay.
We've talked about most of them.
How about transitioning to the adult in a adult care center?
There we go.
That would be
Thank you,
helpful.
Dr. Mohassel.
So no, I have to apologize on behalf of all my colleagues, just because there's very little familiarity with some of the pediatric disorders. Because, you know, to be honest, a lot of the kids just didn't make it to the adult clinics, right? And so it's in transition. I happen to be at Johns Hopkins, where we have a very strong pediatric neuromuscular program, work very closely with our pediatric neuromuscular docs to transition care to adulthood. Not every place is like that, and not every place has pediatrics and adults in the same place. We literally see patients in the same space. So it's, I go and get the pediatricians to see their old patients, you know, right from across the hall. The things that I would say that it's a process on both sides. So it's not like the transition occurs at that one visit when you turn 18 and now everything is on the adult side. I'm married to a pediatrician. They're much nicer than us. They take care of their patients so much better. We try, but you know, it is what it is. Partly, and it's difficult to go from a very protected, proactive team to a doctor that may not even know and may see you just once a year, and sometimes, you know, appears dismissive. So I get all that. So I think my approach is to first build that relationship, and it sometimes takes a few visits. It really takes about a year or two to really build that relationship, get everybody on board, get the transition, and then we start sort of approaching some of the specific things, you know, like bone health, or making sure that pulmonary care is really still adequate. And things like that. The same transition sometimes happens on the pulmonary side. You know, you go from a pediatric pulmonologist to an adult pulmonologist who, again, you know, may start just giving you oxygen. And so then I have to kind of communicate and bring in people to fix that. But yeah, I mean, that's definitely one aspect that is not ideal in the medical healthcare system. That transition doesn't happen smoothly for everybody. You know, I'm happy to converse or help, or if you want to reach out to me to reach out to doctors, I'm happy to do that. And it goes the other way too. So, you know, I've had patients who were seeing doctors when they were younger, and for some reason they just stopped going, you know, when they were teenagers, or they just stopped going to the neurologist or to the MDA clinic or what have you. And now that they're older, either they have other health problems and they're kind of coming back. You know, that's an opportunity to kind of get them back, get the care that they need, get them hooked up to the resources. And again, my first focus for collagen 6 patients is respiratory care. I mean, recently, you know, we'd had to sort of navigate costs of getting coverage for the BiPAP that clearly was indicated, right? And just going through the local pulmonologist, the one that the insurance was accepting, and so on and so forth, and getting medical device. And so navigating all of those, it's a challenge, but we sort of take it one step at a time. Anyways, I'll pause here, but I'm happy to answer questions and also help navigate with anyone who wants to reach out.
No, that was very, very helpful. Rachel wanted to have a comment as well, so if you can imagine that.
You want me to hold it?
I got it.
Okay. It's a 90% or better chance that when you or your kid hits adulthood, you are not going to have an expert in your disease. It's just the way it is. And like Payam said, we've been really great about building up pediatric neuromuscular conditions, but only until recently have we expected lifespans to be close to normal because of improved care, right? So we're totally unprepared in this world for adult neuromuscular patients. So find a doctor or a set of doctors who are willing to say, I don't know, and I'm willing to learn from you, and I'm willing to make you part of my team. Because if they don't have those qualifications, move on, right? You are now the best expert in your condition, and they need to learn from you, and they need to support you. So they don't need to be an expert. So you'll spend years trying to find an expert that doesn't exist in the adult space. Find someone who's willing to work with you and treat you as part of the team, and then help them learn by all the papers that we've got, by the experts that we've got here, who can help them get up to speed.
The good news is that we're a pretty tight-knit network. So when Dr. Mohassel had a question about getting his patient something respiratory equipment, he reached out to Rachel. When Rachel has a question about someone that maybe we can help, she'll reach out to me. So you have a network. You're not in a vacuum. You know, a lot of you know that. I hope you also recognize it. Feel free to reach out because we're happy to help.
And the other thing I was going to mention is that I think this issue is being recognized. It's not completely ignored. So, you know, as part of my job, I train fellows and residents who come through, and as they come to my clinic, they do see patients with congenital muscular dystrophy and congenital muscle disease who are adults. And so that's going to have a lasting effect in their practice wherever they go, and hopefully that will continue. So, and there are initiatives to improve that. The care of adults with neuromuscular disease, but it's not there yet, and we need to do a lot more work.
And maybe I can just make a comment. This made me think of a lot of times when you're in my clinic and I have a resident, I know that doesn't always feel great from a patient side. Or if I'm showing you the same bit of distal hyperlaxity and contractures and keloids, thank you for letting us show off these features in your patients when your kids are with us, because that's how those residents, when they're out there in the community, they'll have ever seen this once in their career. And we really need that space to teach them. And sometimes even I'm like, I hate to do this to this person again, but can you just show me your hyperlaxity, right? And we try to be fun about that, but just having those opportunities in clinic really helps build that expertise in the broader community. So thank you, even though it's hard to be shown off all the time.
I just want to make 2 quick points. I know we have to wrap up. First thing is, try not to use the word BiPAP as you are going through your clinical and your growth over the course of the future. Use the word mechanical ventilation, because that's what we are doing. We're not treating sleep apnea. We may use that same piece of equipment, but I want you to get used to the fact that we are providing mechanical ventilation. We're not treating sleep apnea. Why is that important? For the next part. After any surgical procedure that requires anesthesia, or after any illness for which he or she needs a quick intubation as they're recovering, the goal should be not to stress them out by weaning ventilator support, but when it's reasonable, switch them to from full support of what they were to their full support to what you normally use at home, or maybe a few centimeters of water pressure higher. Do not have the ICU folks pull the tube after your child has been exhausted trying to breathe on his or her own as they've tried to wean support. So it should be from full support to full support. And if in doubt, just reach out.
Yeah.
If in doubt, just reach out. That's a good closing.
But for any surgical procedure, planning those things with your neuromuscular team can help set those expectations. I think the one other little rule I'd put in your head is that never be on oxygen without that mechanical support. So if you show up in the middle of nowhere on a road trip and having respiratory distress, the initial inclination would put you on oxygen, but a patient with muscular needs to be also on their ventilation.
Always have your settings with you.
Yeah. One final thing for our jet-setting adults, who are someone in the room who take long-haul flights. I say BiPAP, I'm sorry, but bi-level positive area pressure. B for BiPAP is your buddy, because take it with you, not just on the flight, take it in the cabin. Put it on during the flight. That will make a big difference. A lot of you have recognized you may feel ill or faint during a flight without the BiPAP. Wearing the BiPAP, you can fly all over the world. And please do so.
Try not to make it longer than 8 hours.
Should we end on that? I think we're over
That was
time.
fantastic. Yeah. Thank you, everybody. There's a couple events going on this evening. Definitely thank you to our panel.
And thank you, everyone.